Anxiety disorders. Anxiety defined as a subjective sense of unease, dread, or foreboding can indicate a primary psychiatric condition. Anxiety can be described as an uncomfortable feeling of vague fear or apprehension accompanied by characteristic physical sensations. Anxiety can produce uncomfortable and potentially debilitating psychological, that is worry or feeling of threat, and physiological arousal, that is tachycardia or shortness of breath. Classification. Anxiety disorder are broadly divided into generalized anxiety disorder, panic disorder, phobic disorder, post-traumatic stress disorder, and obsessive compulsive disorder. Epidemiology. In general, anxiety disorders are a group of heterogeneous illnesses that develop before age 30 and are more common in women, individuals with social issues, and those with a family history of anxiety and depression. United States, the 1 year prevalence rate for anxiety disorders was 13.3% in persons aged 18 to 54 years and 10.6% in those over age 55 years. Symptoms of anxiety: sensitivity of noise, dry mouth, difficulty in swallowing, palpitation, restlessness, tremor, gastrointestinal discomfort, headache, insomnia, constriction in chest, and poor concentration. Pathophysiology, GABA system. The role of GABA benzodiazepine receptor complex in anxiety disorder has not been fully characterized. However, a potential role has been implicated in panic disorder, GAD, and PTSD. In GAD, reduced temporal lobe benzodiazepine receptor are observed. In PTSD, cortical benzodiazepine receptor are reduced. In panic, decreased GABA. A binding is noted. Angiogenic agents having the property of altering the binding of benzodiazepines to the gamma aminobutyric acid receptor leads to nerve cell excitability, leads to anxiety. Serotonin system. 5-HT is involved in the pathophysiology of anxiety disorders as abnormal regulation of serotonin release and reuptake for abnormal responsiveness to 5-HT signals. Amygdala. Its role includes detecting, coordinating, and maintaining fearful emotions. The amygdala integrates information from multiple sensory areas of assess to assess for threats with consideration of input regarding the context of presenting stimulus. Once a threat has been detected by the amygdala, a rapid response is coordinated. Non-adrenergic system. Locus coeruleus, which is located in the brainstem. Locus coeruleus is the neither primary nor epinephrine containing area of the brain. According to the noradrenergic theory of anxiety, in the presence of perceived threat, the locus of coeruleus serves an alarm center. Release norepinephrine leads to anxiety. Alpha 2 adrenergic antagonist, humabine, carbon dioxide inhalation, caffeine, isoproterenol. Each of these stimuli activates a pathways leads to anxiety. Generalized anxiety disorder. Chronic anxiety state associated with uncontrollable worry. Patients with GAD have persistent, excessive, unrealistic worry associated with muscle tension, impaired concentration, and insomnia. Complaints of shortness of breath, palpitation, and tachycardia are relatively rare. Alcohol abuse and dependence are common in GAD patients. Risk factor. Factors that may increase the risk of GAD include family members with an anxiety disorder, increase in stress, exposure to physical or emotional trauma, unemployment, poverty, and drug abuse. Diagnosis and clinical presentation. GAD is diagnosed when an individual experiences unrealistic or excessive anxiety and worry for a period of at least 6 months. Additionally, the individual must have difficulty in controlling that anxiety or worry, accompanying the anxiety or worry for 6 months with 3 or more of following symptoms: feeling tense or restlessness, easily fatigued, difficult concentrating, irritability, and difficulty with sleep. Panic disorder. Panic disorder is defined by the presence of recurrent and unpredictable panic attacks, which are distinct episodes of intense fear and discomfort associated with a variety of physical symptoms: palpitation, sweating, trembling or shaking, sensation of shortness of breath, chest pain or discomfort, nausea, feeling dizzy, fear of dying, paresthesis, chills, or hot flashes. Diagnosis or clinical presentation. A panic attack usually peaks in 10 minutes and lasts no longer than 30 minutes. A patient is diagnosed with a panic disorder when that individual experiences repeated unexpected panic attacks, and these attacks are followed by a 1 month period of one or more persistent concern over future attacks. During an attack, individual will often feel like they are losing control or dying. Phobic disorders. A specific phobia. A specific phobia is any kind of anxiety disorder that amounts to an unreasonable or irrational fear related to exposure to specific objects. Social phobia. Social phobia is fear of social situation where you may be embraced or judged. Common physical symptoms include blushing, diarrhea, sweating, and tachycardia. Agoraphobia. Agoraphobia is a fear of places or situations that might cause you to panic and make you feel trapped, helpless. Phobic disorders are common, affecting 10% of population. The patient avoids phobic stimulus, and this avoidance usually impairs occupational or social functioning. Common phobias include fear of closed places, uh, which is claustrophobia, fear of blood, fear of flying. Patients with social phobia in particular have a high rate of comorbid alcohol abuse as well as of other psychiatric conditions, that is eating disorder. Post-traumatic stress disorder. Patients with stress disorder are at risk for the development of other disorders related to anxiety, mood, and substance abuse, especially alcohol. Symptoms: nightmares, negative thinking and mood, unwanted distressing memories of the traumatic event. Symptoms usually begin early, within 3 months of the traumatic incident, but sometimes they begin years afterward. Symptoms must last more than a month. Obsessive compulsive disorder. OCD is characterized by obsessive thought and compulsive behavior that impair everyday functioning. Fear of contamination and germs are common, as are hand washing, counting behavior, and having check and recheck the actions like whether a door is locked. Non-pharmacological treatment. Psychological education, short-term counseling, stress management, psychotherapy, meditation, or exercise. Psychological therapy. Psychological therapies are generally considered first-line treatments in all anxiety disorders because they provide a longer-lasting response and lower relapse than pharmacotherapy. The specific psychotherapy with the most supporting evidence in anxiety disorder is cognitive behavioral therapy. Therapy usually for 8 to 16 weeks or longer in more resistant cases. Selective serotonin reuptake inhibitor, that is paroxetine, escitalopram, citalopram, and fluoxetine. SSRIs are the first line treatment of GAD, SAD, and panic disorder. Treatment effect usually takes at least 4 weeks. Mechanism of action. The SSRIs block the reuptake of serotonin, leading to increased concentration of the neurotransmitter in the synaptic cleft and ultimately to greater postsynaptic neuronal activity. Side effects: vivid dreams, tremor, nausea, vomiting, insomnia, headache. Tricyclic antidepressant. This is tertiaryamine, amipramine, amitriptyline, and trimipramine. Secondary is desipramine and nortriptyline. Mechanism of action. Mechanism of action of the tricyclic antidepressant is that they inhibit the reuptake of the biogenic amines, mostly norepinephrine as well as serotonin. Side effects: blurred vision, constipation, urinary retention, dry mouth, sedation, weight gain, and orthostatic hypotension, insomnia. Dose and administration. Amipramine initiated with 10 mg per day at bedtime and slowly increased by 10 mg every 2 to 4 days as tolerated to 75 to 100 mg per day, and then increased by to 25 mg every 2 to 4 days over a 2 to 4 week period. Monoamine oxidase inhibitor. The substrate for MAO A enzyme is serotonin, melatonin, epinephrine, and norepinephrine. Mechanism of action: MOIs form stable complexes with the enzyme, causing irreversible inactivation. This results in increased stores of norepinephrine, serotonin, and dopamine within the neuron and subsequent diffusion of excess neurotransmitter into the synaptic space. Dosing and administration. The starting dose of phenylzine is 15 mg per day after the evening meal, increased by 15 mg per day every 3 to 4 days until a maximum dose of 45 mg per day in 2 or 3 divided doses reached. If a patient was an antidepressant previously, it should be discontinued 2 weeks before phenylzine is started to prevent a potential drug interaction. Adverse effect: orthostatic hypotension, insomnia, weight gain, and peripheral edema. Benzodiazepine therapy. Benzodiazepines are effective medication due to their anxiolytic properties and may provide rapid symptom relief. Benzodiazepines may be most useful when used early in treatment in combination with an antidepressant. Adverse effect: drowsiness, sedation, ataxia, disorientation, depression, confusion, irritability, and excitement. Buspirone. Buspirone is a non-benzodiazepine anxiolytic therapy. Mechanism of action: the anxiolytic properties of buspirone may be due to partial agonism of 5-HT1A receptors by reducing the firing of serotonin neurons. The effectiveness of buspirone may take up to 4 weeks. Side effects are mild and include dizziness, nausea, and headache, stomach upset. Initial dose 7.5 mg twice daily, with dosage increments of 5 mg per every 2 to 3 days as needed. The usual therapeutic dose of buspirone is 30 to 60 mg per day. Thank you.